Hello, hola. Welcome everyone to this edition of Conversations on Cancer, brought to you by the Food and Drug Administration's Oncology Center of Excellence. Something special today. This is the inauguration of our National Hispanic Latino Family Cancer Awareness Week. It's an initiative that starts with this conversation on cancer, as well as a social media campaign running today through the 26th. This is all in correspondence with the Hispanic Heritage Month. So we strongly encourage you to use our hashtag Latino Cancer throughout the week and the rest of the month, should you choose. You can find more information on it on our webpage, National Hispanic Latino Family Cancer Awareness. And you can also send us any comments that you'd like for us to know about today's conversation on cancer, about this campaign, anything that you'd like to share with us. The email address is there on the webpage, National Hispanic Latino Family Cancer Awareness. I'm Rhea Blakey. I'm the Associate Director for External Outreach and Engagement here at the Oncology Center of Excellence and lead Project Community. And we are so thrilled that we're able to bring this initiative to life. We've been talking about it, I feel like, for years, but it's a good thing. So we're glad to be on board with that. We don't get anything done without supreme leadership, and our best cheerleader actually is our center director, Dr. Richard Pazder. Hey, Rick.
Hi, how are you doing? Thanks, Rhea, for the introduction. My name is Dr. Richard Pazder, and I'm the director of the Oncology Center of Excellence here at the FDA. And I'd just like to welcome everybody to this really special edition of Conversations on Cancer. Conversations on Cancer is our initiative of the OCE, really to integrate what we do here at the FDA, our regulatory work, our scientific work, and bring that work and integrate it into the community to really bring what we do to the various parts of the United States and its territories, really to bring drug regulation to the people that we serve. I'll just leave it at that because I know we have an action-packed hour here. So I'll hand it back to Rhea.
Thank you. You noted that Rick is going by first name, and we've all decided on this particular meeting that we will agree to do that, just to sort of keep things moving as quickly as possible. Plus, they're all great friends. Everyone knows each other. I do want to make sure to mention two of the colleagues who have worked strenuously to pull this off, and that would be Donna and Luxon. Donna, I'm going to ask you to make some comments first, followed by Luxon.
Thanks, Ria. Buenos días y bienvenidos. Estamos muy felices para esta conversación con la comunidad. Good morning, all. I'm Donna Rivera. I'm a pharmacist and pharmacoepidemiologist by training here in the OCE, and we are so excited to hold this inaugural conversation, which, as mentioned, reflects at least a year of effort to put together an authentic and accessible program for the Hispanic and Latino community. As a bit of background, according to a recent Pew report, there were 63.7 million Hispanics living in the United States in 2022. The Hispanic population is among the fastest growing in the United States, representing 53% of the US population overall in the past decade. And the Hispanic population has diverse origins spanning Latin America and Spain. And so including the Hispanic population as the newest part of project community efforts in the OCE and creating this conversation around cancer prevention, screening, clinical trials, knowledge, and hope, we've brought together experts in this area for this conversation, and we're all embracing the tagline, Avanzando Juntos. So with that, I'd like to turn to my colleague Luxon to introduce himself.
Thanks, Donna. My name is Luxon. I'm a medical oncologist here at the FDA. I'm extremely excited to be part of this panel. I mentioned to them earlier that we're going to break all sorts of records today. We have 3 different interpretations going on simultaneously live. And so we've asked our group in 1 hour to start to unpack some of the delicate, sensitive topics that relates to the Hispanic Latino population in regards to cancer. So they're going to be carefully but efficiently and effectively going through this conversation. In addition to that, I would like to let you guys know, everyone know that we're being as inclusive as possible by providing these 3 different translations, and also going to allow my colleague, Bernardo, to introduce himself as a representative of the Brazilian population. So Bernardo, can you introduce yourself?
Ok, bom dia a todos. Good morning, everyone. I'm Bernardo Goulart. Like Luxon, I'm a medical officer at the FDA, and I am also very excited for providing the Brazilian perspective as a healthcare provider and hope to represent a little bit of the voice of Brazilian patients as well, if possible. Thank you.
Thank you, Bernardo. I'm going to hand it over back to you, Ria, and we'll continue introductions.
Excellent. We mentioned jam-packed, and we weren't kidding. I'm going to ask each of the panelists to briefly, please, introduce themselves. And if I miss anybody, we'll pick you up on the back end. But for now, let's start with Maria.
Good morning, everyone. My name is Maria Garcia Jimenez. I recently joined the FDA actually as a clinical reviewer. I'm a medical oncologist by training, and prior to joining the FDA, I worked in a safety net hospital providing oncological care to a majority Spanish-speaking Hispanic Latino population. I also conducted clinical trials, and I did health services, health equity research, primarily focused on increasing participation and understanding about clinical trials in the Hispanic Latino population. Very excited to be part of this panel. Look forward to our discussion. Thank you.
And so those are all of the folks from the FDA who are represented on this call. Now let's go back to Marcia.
Good morning, buenos dias. Thank you for the invitation. I'm a gastroenterologist focusing GI malignancies. I work at the University of Puerto Rico, and for many years, I've worked into trying to improve access to clinical trials. The last 6 years, we actually put together a community research network so that we can train the community physicians and clinics to really provide access. And that has really transformed the way that we reach the community. And looking forward to participating in this novel and very important meeting. Thank you for the invitation once again.
Oh, thank you. Good morning, Isabel.
Good morning. Good morning, everybody. Nice to see some of my colleagues here that I've worked with for so long. I'm Isabel Duran. I'm the founder and executive director of the Latino Cancer Institute. We're based in California. We aim for 3 things. That is to amplify the Latino voice and concerns over issues of cancer. We collaborate in research, and we drive systems change in order to diminish Latino mortality. Thank you. I'm glad to be here with you all. Good to see you.
Thank you. And speaking of driving, Ivis, we see that you are in a vehicle, but we're actually just glad to see you. So if you would unmute and introduce yourself quickly. Hi.
Hi, everyone. Sorry about that. Internet crashed at someone else's house, and here we are on the road trying to get home. But anyway, thank you so much for this invitation. I appreciate it. I'm very proud to be a part of this group. And I'm a patient advocate for 31 years, also a patient who was diagnosed and misdiagnosed for 18 months and at the young age of 38. So that propelled me to get involved, to make action happen and to make change happen for the best. I retired from Shared Cancer Support as their chief officer of diversity and inclusion. And we had specific projects for the Latino, African American, and Japanese communities.
Great to have you. Thank you so much. Also, Frank, good morning.
Good morning, everyone. It's a pleasure to be here. I'm Frank Pinedo. I'm professor of psychology and medicine at the University of Miami. I'm also associate director for population sciences at our Sylvester Cancer Center, and I'm trained as a clinical psychologist and in behavioral medicine. Most of my work is in Hispanic cancer survivorship.
Wonderful to see you again, Frank. And new to the conversation on cancer family, if you will, Fabian. Hi.
Hi, good morning. Good morning, everyone. I'm Fabian Sandoval. I am the president and CEO of Emerson Clinical Research Institute. We are a dedicated research site here in Washington, D.C. with a very strong foothold in the Hispanic community, providing a variety of clinical research activities. I also co-host a TV show, a national TV show called Tu Salud, Tu Familia. It's a one-of-a-kind TV show. We've won 4 Emmys, and we've done 190 shows, all on access to care and providing education to the communities across the country.
And I believe that's also on Univision, yes?
Yeah, it's actually on Telemundo. So you can see it on Telemundo, and you can watch it on YouTube as well. Just look up Tu Salud, Tu Familia or our website. But that's just not my day job, but it's the job that educates the community on the importance of what we do to provide access to care.
Right. And we're all about reaching the community. And with that, I'm going to hand things over to Donna and Luxon to really get the conversation started. Welcome to all of our panelists. Donna, Luxon?
Hi. You missed Dr. Flores.
Oh, did I? I knew it was going to happen. There's so many people here. I apologize. Please go ahead.
It's all right. So I'm Dr. Narjas Flores. I'm the Associate Director of Cancer Care Equity at Dana-Farber, and also the Director of the Flores Lab, and a 200% Latina that's here to change how we train the next generation of Latinx physicians, and also to understand the needs of our patient where we are needed, which is in the community.
All right, good catch. My apologies. All right, Donna. Okay.
Yeah, thank you very much. I said we're going to break all type of records here today. Before we go even further, I do want to mention that, you know, one of the big struggles that we had was how do you be as inclusive as possible? And even with the name itself of the National Hispanic / Latino Cancer Awareness Week, I know it's a mouthful. We decided to also include Latino, being sensitive to our Brazilian population. And so, you know, I hope that you see our heart behind this and that we want to be inclusive, but at the same time, balance that with the differences that do exist between these two populations, because it's a very heterogeneous population. But yet we still think the effort, it must be done in order to address the issue of cancer and these very great population of people. What I would like to start off is with the conversation of La Familia. We've talked about community, we talked about families in other previous conversations with this group and other panels, and we feel like that's the right place to start and focus it in. So I guess the first question would be, and it's open to the entire group, what are the challenges in talking to the community, the family, the Hispanic, the Latino population on the topic of cancer?
Recording in progress.
So if we can just start off, I'm opening it up. What are some of the challenges when we talk about cancer, where you talk about screening, being aware of the cancer, the term itself? What are the issues there?
So if I could start, Luxon, there are many, and I'm sure we all will have our own. I practice in Puerto Rico where everybody, you know, is Latino, everyone is, you know, speaks Spanish. But even there, the word cancer, it really carries a big burden. You know, there's still some misconceptions about, you know, why did I get cancer and do I want to even talk about it, right? So I think that's one of the biggest barriers that we still see. The second one I would say is the limited screening based on the tumors that, you know, are present in the community. We see a lot of infectious diseases-driven tumors, like, you know, gastric cancer, H. pylori, you know, that we continue to get infected because of the, you know, environmental exposures, but also, you know, things like HPV-related cancers or hepatitis C. So, you know, thinking about, you know, why did I get cancer, but even thinking on prevention, just to name a few.
I think Marcia really hits it on the head, because what we're talking about is lack of information in several languages, right? And that is part of the big problem. This fear, myth, and misinformation goes through our communities, and they're carried forward sometimes by social and cultural beliefs that really create some of those barriers. And therefore, we really need, I think, a major investment in community health workers who we can deploy to these neighborhoods and to these individual groups, recognizing their own historical and social context so that they can start to address these very issues. I think that's very critical.
I'd like to add to that also with respect to the work that's being done in early detection, as well as support and treatment, and speaking to your family members. I think, you know, we need to break all these myths that are out there that are incorrect, using, of course, our own community's voices, leaders, community health workers, just as Isabel said, working with actual survivors. At SHARE, we worked with survivors that we trained to go out into the community to help break the myths, but also to tell them the importance of sharing your information, that you have survived cancer and that you're alive and now you want to get back to your community. And that hits the heart, because then people realize you can deal with cancer. You must tell your family members. And let's face it, generation-wise, people never spoke about the big C. So this was happening in both English and Spanish communities, and we're at least 10 years behind. So we break those modes. And by the way, yes, that is a fan, and I'm home.
Oh, thank you. I see Bernardo has his hand up as well.
Yeah, so at least in the Brazilian community, I see many different levels interfering with the interpretation of word cancer, starting from basic knowledge on cancer risk factors. Like as someone pointed out, many of these cancers are related to preventable factors, including infectious, but also diet, tobacco consumption, alcohol consumption, and even though we have data, the information is not really out there in the Brazilian community to link behaviors and risk factors to incidence of cancer. But also in terms of diagnosis, we have some cultural barriers in that, patients and some families, they sometimes oppose to this, direct communication of a cancer diagnosis. I remember when I was in training in oncology, still in Brazil, or coming to the United States, I was sitting in front of a patient with a recently diagnosed lung cancer, and the family would stand behind me, waving big nose, communicating to me their preference not to disclose a diagnosis of cancer. I'm sure this happens in other cultures as well, but I want to point out there are some cultural barriers in accepting a diagnosis of cancer in the Brazilian community.
Frank, and then Maria, please. Frank?
Yeah, I completely agree with my colleagues. I think we shouldn't also lose sight of the fact that there are very significant structural barriers within our Hispanic communities that also have an effect on how cancer is managed or perceived, and particularly screenings and how risk behaviors are managed. Hispanics have some of the lowest rates of insurance in the United States, so access to care is a problem. But with that said, even in the presence of access, we have these cultural and psychosocial barriers that still fully operate. Hispanics also have a greater disease burden in many ways in terms of diabetes, kidney disease, and obesity, and collectively these can all impact also thinking about preventive behaviors when it comes to cancer. From a sociocultural perspective, I think some of it was touched upon already. The family is extremely important, and perceptions about the benefit of screening and addressing cancer risk or cancer control once an individual is diagnosed, that it's not only going to benefit the individual, but it's going to benefit the family system. If you're going to be able to take care of yourself, you're going to be able to take care of your family. And I think we need to do a better job at reframing some of the messaging and the community outreach that we have to make sure that we get those messages across to our Hispanic community.
Can I add, Rhea? I think that part of the problem is we spend billions and billions of dollars on trying to help a sick country instead of putting money into prevention so we can start to really address these basic community issues and hopefully diminish and reduce some of the things that Frank is talking about. But we're trying to put Band-Aids on a big problem. And so we need solid education in our communities. And I think we have to start at high school. Bring back health science classes, right? We really, really need to get into our communities to start to address these factors. Otherwise, we're going to see this over and over and over again. I don't see it changing.
What's happening. Yeah,
we're not going to meet the moonshot goals, that's for sure.
Yeah,
Maria.
Yeah, I think I agree with a lot of what's already been said, and from a clinical perspective as a physician, I think something I've observed frequently in our communities is fear of cancer, which I think was mentioned, and sort of this misconception that any cancer equals death immediately. And I think that goes along with not engaging in preventative measures and screening measures and not quite understanding, the importance of those and how to access them. So I think from a physician standpoint, understanding of these concepts in our communities is really important. And I agree with Isabel and Evie's about, community health workers and navigators. And really, I think as a health system investing in prevention, that is really what is going to drive down the cancer burden amongst our communities.
MJ.
I think the big change is about changing the message. We do know that or gente or agente in Portuguese are afraid of the cancer. But we need to change the speech. We could keep saying their families don't want to. Why? We always have to go beyond the no. I always go beyond the no. Why do you don't want to disclose the diagnosis? As the daughter of two patients with cancer, my mom and my dad, I have seen how each of them see it differently. But why do you don't want me to tell your grandma or your mom about cancer? Let's go out in the hallway and talk. Because a lot of this fear is based on myth. We have a lot of myths in our culture. So that's how it starts. It starts in the clinic to eliminate the taboo around the word. Instead of saying, like the word, I'm not going to say it, should I say it? Like the word vagina, right? In cancer. We need to talk about it. The more we mention the word cancer, the more our families and patients will feel more comfortable. And instead of saying the tumor or the growing lesion, we have to call it like it is. Same thing about death. Not passing away, death, right? So that will make our community feel more comfortable. And I always try to use those two words, of course, cancer and vagina.
So we're talking about a lot about reframing, changing the messaging. Fabienne, I'm going to bring you in this conversation because you do work with this. What are your thoughts on all of this?
Thanks. One of the biggest things that I've seen in the work that we do in the community is what everyone on the call has been talking about is mainly developing that level of trust, is getting rid of some of these myths. We actually put together on our show a segment called Mitos o Realidades, and every single time we talk about mitos y realidades, sometimes they're funny, sometimes they're serious, but we have to break a lot of the rumors that happen, that some of the home remedies that exist that don't really work, or what are the reasons why people are getting these treatments. The biggest one, if we're talking about screenings can be very difficult. Latino men don't want to get a prostate exam, right? So the first thing I say is, don't worry, it's not a digital exam anymore. Let's start with the blood sample. After the blood sample and things work, then maybe you need a digital exam, and I'll get you ready. Don't worry, it's okay. Everyone has to go through it. But letting people know that there's things available that is not so invasive, not so scary to do, and cost effective, which is why we bring clinical research into all of our conversations. It's cost effective. I don't care. We just did a TV show. I just recorded 3 TV shows before starting. And the things that we always talk about is, I don't care about your legal status. I don't care about how much money you make. I don't care where you live. I just need you to come in to get help. And I think once we tell them that and we speak to them in their language, hablamos español, no se preocupe, aquí estamos todos para ayudarle, it opens it up. I think that is the biggest thing, is getting that level of trust in hand, on the radio, on the TV, in person when we go to the consulates. Just bring them into the clinic and we'll take care of them from there.
I think that's such an exceptional point, right? And really meeting people where they are, right? And creating those accessible frameworks, and building on the efforts that you're doing. Frank, I wondered if you wanted to talk a little bit about the work around misinformation and build this part of the conversation.
Yeah, as I mentioned earlier, I think this community awareness campaigns are extremely important. We work with federally qualified health centers, and we work with quite a variety of community-based organizations where we try to get the messaging out, particularly in venues that are not threatening. So it's not coming into a clinic or being with a physician, but maybe in a community fair, a fair specific to, for example, celebrating the independence of a country of origin. And there the messaging tends to be a little bit easier. And I think to what Dr. Sandoval was talking about is demystifying that fear and that misinformation that is so prevalent in our communities. I can tell you that we have patients in our communities or community members that stigmatize the word cancer as HIV was stigmatized in the 80s. I mean, they don't even want to say the word cancer because of this fear of lack of controllability. We know, and not stereotyping our Hispanic communities, but Latinos tend to have fatalistic attitudes about chronic disease. If I have it, I'm going to die from it. And if I don't know about it, nothing's going to happen to me. So reframing that messaging at the community level, I think will go a very long way at helping us get screening in place.
Yeah, jump on in, Ibis.
We just have to talk to patients as equals. I always say, I may have a suit on, I may have a lab coat on, I may have a tie on, I take it off. It's like, we are all equals. At the end of the day, we're all the same. And I get serious with them and I say, take your medicine. Why are you wasting my time if you're going to take your medicine? Why are you wasting your money? Come in. it's free, or what we're doing is like, I'm here for you. Get real with them. And I talk to men very honestly about their situations that they have with health, and stop it. Stop worrying about it. Just get it done. Come in and demystify the whole thing. Just like Frank is saying, it's from that moment, just do it with us, right? It works, everyone. It works as long as we're honest with our patients. And if they're, like you said, Frank, if you give it a name, now it's called cancer. Now it's real. Now it's going to happen. So Latinos love to walk with like horses, right? With this little side view. So we don't want to look to the side or left, right? I don't want to be told I have a condition, but once I'm told, then I have to do something about it.
And I'd like to add to that's what we did at the Latina Share program at Share. What we did is, and they continue to do because I've retired from Share, they train our ambassadors, which are basically community health workers. But these women have had cancer themselves, or they're family members of cancer survivors. They're passionate about what they're doing. They really want to help their communities, and they speak their language. So what we did is we started a program first at the Mexican consulate, and then now we're at almost every consulate in New York City, where they're able to provide not only our materials, but the passion that these women bring behind their wanting to educate the community. And people see, oh, she looks just like my sister. She looks like me. She could be my mother. And they connect with that because they know they really are sincere and want to help them. What I also did was I developed and designed a novela, but this is a comic book style paper novela, where we started to break some of the myths that we were seeing coming into our support groups and into our community. And I wound up doing it almost like a research, because what we did is we were able to get survivors of breast cancer and ovarian cancer, some that were not, and we held a variety of focus groups. In that group, we made sure that we had not just, Mexicans or Puerto Ricans, but we had every country that we could get involved. We had about 12 countries involved from Central, South America, from Spain, from Puerto Rico, from the Dominican Republic, and Mexico. We made sure that the language that they were using, this was recorded, as well as the myths that they were coming back with. And what we did is we plotted a story that carries in between that, the myths, but also the actual true realities. And truly this important. Way, we're able to educate them.
Yeah. Let's go with Marcia, then Maria, then Bernardo.
Thank you. I want to go back to the topic of the families, right? And how important are the families for the Latino community. And when you think about looking at the family history, I see the extreme of that, right? I take care of patients that have germline mutations. That is, they inherit the risk for developing cancer. So once I have a patient that, has this, higher risk, then we need to speak with all the first-degree family members to see who else has inherited the same mutation. And then once we have that information, then we can be proactive and prevent cancer altogether. And the biggest challenge that we have is that once I have a patient that has a mutation, which we call it now a pathogenic variant, then that means that he or she has to reach out to the family and tell them that they are the ones that have this. And there is all this conception about the guilt of being born with an increased risk. And believe it or not, we have had to switch the way that we do this. And basically, we just ask for permission and we start doing things like what we're doing right now, right? We do video conversations where we start talking about, what is to have, this syndrome? What does it mean for you? And that's how we've been able to reach into the families. So imagine that. We have to change the current format. It's not to give a brochure. It's really to be part of the conversation with their families to be able to, have this information, be powerful, and then prevent cancer.
Mm-hmm. Maria, Bernardo, then Isabel.
I wanted to just make a comment that I think goes hand in hand. We're talking a lot about providing education, building trust, breaking down myths. And I think all of that is very, very important. I commend all the work everyone is doing, but I don't think it can be successful without actually increasing access to healthcare, right? If we're talking about screening, what happens after somebody, for better or worse, has a positive screening test, right? We need to be able to, as a healthcare system, and Isabel was talking about all these Band-Aids, which I think is a bigger conversation, a bigger problem, but we do need to think about how can we also increase access to healthcare while we are educating the community, telling them to go get screened. You know, they need to be able to have something to fall on, to have access. And not in all states, in all counties, in all communities do we have clinics like perhaps Fabian's, where, you know, they can come in regardless of their legal status, their health insurance status, et cetera. So I think that is something very, very important and very key that we also need to talk about and think about in parallel to reaching out to the community, building trust, and having more awareness and education.
Bernardo?
Yeah, so since we addressed myths, we can exercise a little bit, an effort. You can make an effort to determine the roots of these myths. In the Brazilian population, I see like two roots. One of them is fatalism. Fatalism, the notion that once somebody faces a cancer diagnosis, that person is condemned, so to speak. The treatments are almost like a punishment because of the side effects, and the cancer itself is a punishment. So why bothering looking for a diagnosis like that, since the result of that is some kind of damnation? So fatalism is one root, I would say. The other one is this very close connection between religion and health. So Brazilians, particularly those of like, more simple backgrounds, they tend to connect religion and health in the sense that we are largely a Christian population, and they believe that by praising, our Catholic or Christian God, that will protect us from any diagnosis, hence no need for care. While at the same time, once they get a diagnosis, they see that as a punishment from God, and that in itself generates so much guilt that impacts their willingness to receive care for it. So how to think on roots in terms of religiosity and fatalism, at least in the Brazilian community.
Want to give Isabel a chance to respond, but right after that, and I know there's some hands up, but Donna, I know that you also wanted to talk a little bit more about clinical trials, because as we ease into this idea of treatment, obviously those cultural issues are extraordinarily important, but there are things on our end that we'd love to see happen as well. So after Isabel, Donna, would you mind? Okay, Isabel.
Thanks a lot, Rhea. Well, first of all, we have to remember that cancer doesn't begin at the clinic door. Hence the need for a lot of public education. But once we navigate them into the clinic, they run into many more access barriers. We don't have enough Spanish-speaking oncologists or medical doctors to actually serve the 63 million Latinos we have across the country in federally qualified healthcare centers and in clinics where most of the low income particularly go, or public healthcare systems. I've seen that here in California, despite 39% of the population being Latino. They don't have enough, and then we see a lot of bias in the system that also turns off the patients and makes them feel unwanted and unlistened to, so we've heard that. But I've also done some research in federally qualified healthcare systems as we tried to help women get access to genetic testing after we showed a family history and the fact that they might be at high risk. We worked with one clinic. It took us 16 months from when we identified that woman to get the clinician, the one clinician who could even talk about genetics, to be able to see her. And then once he saw her, we ran into payer protocol and policy issues. So these are huge barriers to just moving into systems, through systems, getting proper diagnosis timely, and then treating them in a timely manner. So I think this is another reason for late detection. And I don't really, once you educate the community, they move. They want to know, they want to learn. I moved 5,000 patients into education. We navigated 1,000 Spanish-speaking patients. They just need someone who can speak their language and understands that fear, and then can move them onward. So, Rhea, there's just systems issues. And this is why, we can put We need to put people in the community, and we need to get those doctors in the clinics. We need to create a pathway of affordable education and medical school for Latino students.
Mm-hmm. Donna, I know I set you up, but NJ has been patiently waiting. So NJ, do you mind going first? Go ahead.
Yeah, so I just want to follow with Isabel, because we often believe we need to wait for a very large system to fix the issues that Isabel mentioned. Mm-hmm. A lot of people were like, oh, NJ, you're moving to Dana-Farber, to the ivory tower. So I came to infiltrate like a Trojan horse. And I have done it. In the last 3 years, I have been able to open 2 cancer diagnostic clinics and federal qualified healthcare centers that are staffed and funded by Dana-Farber.
Wow.
Partially awesome. Philanthropy funds, partially grant funded. But now we are in Dorchester and we're Witter Street. So one is in Jamaica Plain and one is in Dorchester, very underserved areas of Boston. How did we staff the clinic? Our navigators were trained, the formerly medical assistants of that clinic, because they understand the community. I don't need to transplant Emily, who never been there. I need Maria, who has been a medical assistant in that clinic for 20 years and knows everybody. By the way, walking with Maria in the streets in Dorchester is like walking with the mayor. But the point is, we have the clinics, the clinic has been there, and we have been able to accelerate diagnosis. But most importantly, the trust. So now we're getting somebody referred the tia. So we have one patient and the patient's like, I brought my tia with me just in case. It takes time, but it's possible. We have increased lung cancer screening by 300% in African Americans and Latinos in these clinics. We are in the clinic once a week, and we have now genetics that was added 18 months ago. And now we have a genetics clinic once a month. Not great, but there was no genetics clinic, right? Mm-hmm. So a lot of people say, oh, once a month is not enough. It's like, well, before there was no month, no everything. But so it's possible. It's possible to do that. Does it take work? You bet it does. Mm-hmm. But
and money.
Anything that's sustainable needs to happen. So some of these clinics have been there for a long time. We can modify them, give them some steroids with philanthropy funds, and then we have been able to do that. And now we're going to open one in the Maryback Valley. So it is possible to infiltrate the ivory tower, to move people to the community, but most importantly, to get the trust. But we're only 3 clinics. So we need this model to be adapted by other large places that we're happy to meet to open these clinics again. You know, it doesn't have to be the 3 clinics that the Cancer Care Equity Program opened. It should be the model that we develop in every large institution. NYU, call it Fred Hutchinson, will have this, hopefully. But it is possible, Isabel. I'm working on it. I'm infiltrating little by little like a virus.
Donna?
It's really, you know, I think an incredible example of what's possible. And I think, you're building on that and thinking about what you needed to do that in the larger community. We've talked so far about the importance of language, cultural beliefs, patient representation, access. But I think another important part of this conversation is about providers, especially as we talk about increasing representativeness in clinical trials. And so there are many studies that are discussing the importance of provider relationships, and it's notable that Hispanic and Latin origin population is around 17% in the United States, along with the increases over the past decade, as we discussed earlier. And yet less than 5% of practicing oncologists identify as Hispanic or Latino. So Narjas, you had a really topical paper on this, Donde Están, and also a lot of work ongoing in Latinas in medicine. Could you talk a little bit more about representation and inclusion and where you think opportunities are to empower the Hispanic and Latino scientists and physicians? Narjas?
All right, I think by now you will know how to unmute yourself, but no, I still need to learn that. I think one of the challenges we have is that we have very large competition, let's be very honest. In our culture, the surgeons are acquired to a higher standard, and there's a lot of challenges when it comes to what you want to do and why your abuelita tells you what kind of doctor you want to be. I think my abuelita wanted me to be a pediatric cardiac surgeon. That was her goal. That was like the ultimate test, right? So we also had those things. you have those barriers, you have the first generations that don't have funding, the lack of role modeling, and these horrific stories that now are coming out with social media about what it's to train to be a Latina. So it is a very hard place to start with, right? I think the brave, we join this and decide to stay, because there's also a lot of that may leave. It is an issue because, let me start chronologically speaking. We are not recruiting more Latinx Hispanics into oncology in the last 15 years. Dr. Velázquez Mañana for UCSF conducted a study that evaluated the matching in oncology fields, including radiation oncology and surgical oncology, and evaluated over time based on the ANC data. We are not improving the amount of Latinos that we are recruiting. Anything we had done so far until 2022, when the publication was shared, hasn't really worked. And when you look after fellowship training, 1/3 Latinos stay in academia and the others will go to private practice. And now we're seeing a large exodus to industry because it's the lack of inclusion of us, the lack of value to what Latinx providers have. So I told my trainees, and Maria may be, academia as a Latina in oncology is like a stream sport, like motocross. You need to be ready for up and downs, and you need to be ready to follow your bike, get in, toss off the dust, and go in. We only have 2.8% of physicians in the United States are Latinas, and around 5% are Latinos. So you may be an entire institution in which you're it. And that comes with the, just going on the journey, the minority tax, right? Every time there is a new medical student that's Latina that wants to do oncology, I get an email. That's part of the minority tax. We need you in this panel. And sometimes I'm like, this is about AI, and I don't do AI. And it's obviously the diversity talking, right? Mm-hmm. So it's often reminded that you need to pay this tax, you need to face discrimination, and you're valueless, and you're less likely to be funded. So will you stay is the question, right? Will you stay? And bravery runs out, and courage runs out. I have stayed because I own it to the next generation so they don't have the trauma I have during training. I own it to them because nobody who had the trauma I had, and many of you have heard my white coat doesn't fit, which is my ASCO voices. Nobody should have that trauma. So I'm here to break that down and be a text away from my mentees so they know that they belong and that they're valued.
I think that's very important that you
Very long answer.
I think that's important what she said. And that issue is not unique to the Hispanic Latino population. That exists in the African-American population too, just as well. And I think that goes back to leadership. I think in this panel here, you see a diverse leadership, even here, a group representation here at the FDA. I think it's very interesting that we are able to have a Brazilian, Hispanic, African-American representation here, just bringing this about. And I think that goes back to leadership and deciding who you pick to get that job, to have that position. And so again, kudos to Rick, thinking not only this ideas, but making that a priority, that diversity does matter. And we're not going to spend this time talking about diversity action plan and all of this, but the fact that, NJ, that you can stand there. I've been to Dorchester. I went there every Sunday when I was at Harvard. I would go there to church. So I know a lot of those guys out there. I know that community very well. And I'm happy to hear that you're doing that. But I think it's very important that leadership, people who make the decision of whether they're going to hire or not that individual, need to be sensitive to these type of needs and need to want that. Because if you don't want it, it's easy to pick the other person when someone is just as qualified. So I talked enough. Let me come to you, Frank, Ivis.
Dr. Matthew,
Isabel's going to interrupt. Go ahead, Isabel.
I'm going to interrupt because I have to leave you now. We are launching our Friday Forum series in about 15 minutes. And close, we hope to see you come later and speak with us at the end. But thank you very much. This is great. I'm so sorry to leave you, but I'm glad we had the conversation. Let's work together some more.
Thank you so much for joining while you could. We appreciate you.
Thank you.
Yeah, Frank?
Yeah, Luxon, just a very quick comment. I completely agree with the comments about our workforce needing to reflect our communities. I think it's also important to realize that that doesn't necessarily guarantee that we're going to do an effective job. There is some work that has shown that even Latino and African-American providers have implicit biases about clinical trial participation. So thinking, oh, my patient, they're Latino, they have a big family, they're really not going to get it, they're not going to participate. So I think we need to do a better job also at training our providers also Latino providers to convey the message about the benefits of trial participation.
That's such a great, I think, transition, Frank, to the discussion around clinical trials, right? And thinking through what the biggest issues facing clinical trials are among the Hispanic and Latino community. So I'm going to start with the patient perspective, and then we'll go to Maria to begin the clinical perspective. So I believe you already have your hand up, but Ivis, go ahead.
As far as patients and getting involved in clinical trials, we see a lot at SHARE, and also I'm involved in a project that's funded by Stand Up to Cancer, and it's called Disrupt. And it has 3 aims. It's going into the community, making sure the community leaders get involved. In that group, I am heading a group of community leaders within the Mount Sinai, Columbia University, Montefiore Einstein, and CCNY. And we're going out into the community to, again, break the myths, to make sure we get from the community, why aren't you participating? What have you heard about clinical trials? And then addressing it in a variety of ways, whether it's outreach into the churches, whether it's getting presenters from the oncology field, and including patients, because they themselves, in many cases, find out that they can be in a clinical trial. But in many communities, it's actually the exact opposite. They're not asked to be involved in a clinical trial. Many of the providers assume, well, this person comes from a community of color. I know they have a trust issues, so we will not, even ask them. But that's the biggest mistake you can make. If you ask someone, the majority, they did some research, I think it was through the Metastatic Breast Cancer Alliance years ago, a lot on the African-American community. And the women were saying, if you would have asked me, I would have gotten involved. I myself have been involved in 2 clinical trials. One was international, that was for my treatment years and years ago, 31 years ago. And then the other was using acupuncture for neuropathy. And again, it's about asking the communities, but also ensuring that within these clinical trials, that the information is translated correctly, culturally sensitive, with health literacy brought into mind, into the languages. With Disrupt, everything that we do, from what's listed on our website, what's going on to the community, the PowerPoint slides for presentations, every single thing was done with community leaders. And we discuss it and make sure that when we're speaking, that we're doing exactly what the community needs.
Right.
African-American, Japanese, and Spanish.
Want to quickly interject for the panel. I know we said we had an hour and it's quickly dwindling. And this is the point at which I just want to remind everybody that we might be getting into your final comments, whether you recognize it or not, because there's so many of you on the panel. As we do this sort of last round robin, if you will, just sort of keep in mind, I know Donna had set us up to go to Marcia next. But, keep in mind, this might be the opportunity for you to say the last thing you get to say during this live panel. So just a heads up. Go ahead.
Yeah. So going back to the community and how can we increase participation of diverse population, including our Latinos? This has to start with trust. The easiest way to have a patient to say yes to a clinical trial is that the doctor or the healthcare provider that sees the patient is the one that is conducting the trial, because there's already the element of trust. If a patient has to go online and find a doctor at another clinic, that already becomes a burden, unless that primary physician says, this is what I want you to do, because the element of trust is key. So one way to really overcome this is really to empower communities, community doctors, community clinics, like it was mentioned before. I think Fabian was talking about how to integrate this into the clinical community setting. That's how we did it. So basically, clinical trials are part of what we do every single day. A patient walks in, they get evaluated. We talk about the standard of care, and clinical trials from prevention, diagnosis, treatment, it's presented. It's not something that is done at the end of the life of a patient with cancer. On the contrary, we talk about it even from the beginning, not only for treatment, but also for prevention or development of diagnostic tools. The only way that we are able to do that is by empowering the people that take care of patients. So that means training, that means access, that means infrastructure, that means working with what's already established. But I want to go back to what was mentioned before by Dr. Narjust. It's possible. It's possible, and we can do it. We don't need to have someone from the outside to simply do it. We can work what's already available to make it happen. There are multiple organizations, including the FDA and the NIH and CI and many others, that have funding, including, for development of, community-based clinical trials and training. So, it is an opportunity. It is not, I want to end up with a positive note, this is something that can be done. And we are showing that it's done. And we've done it in Puerto Rico. We have over 10 sites currently that are trained, community sites, to do clinical research on a day by day.
Thank you, Marcia. I'm going to go over to Bernardo, Maria, and then Fabian.
Yeah, thanks. So on a pragmatic side, I will say one thing about the Brazilian community that resonates all things oncology, including clinical trials: social media. Brazilians are huge users of social media, and one solution is to use social media wisely and appropriately to gather their attention for all things oncology related, including prevention, screening, treatment, and clinical trial recruitment. Brazilians, they are the third country. Brazil is the third country on Instagram, is the third country of using YouTube videos, and is the fourth country of Facebook users. And I agree with all the other ideas about bringing the community clinics, open access to the Latin population. But at least as far as Brazilians go, using social media resources wisely, selecting the right people, selecting the right models and the right messages could have a huge impact in oncology care. And that should be my final remarks.
Leveraging technology and bringing it into the clinical trial is very important. Maria.
Yeah, I agree. It can be done. Representation in clinical trials can be done. And I think for me, clinical trials really highlights the importance of everything that we've talked about separately, right? Trust building, working with the community, representation in the healthcare workforce that Narjust was talking about. And I think one thing I wanted to highlight about her story is that the reason that it can be done is because she is there. That's why it's so important for all of us to be there, to be where our voices can be heard, to be where we can advocate, to be where we can gather, donations and support, whether it be infrastructural or financial, right? That's why it's so important for us to be there, to represent our communities and to advocate for them. It can be done. And ending on a positive note, as an example, in the research I was doing prior to this new phase in my career, a clinical trial that I was running, working very closely with a Spanish-speaking Latina clinical trial navigator, about 65% of our participants were Latina Hispanic, and we conducted alongside the clinical trial a qualitative aspect to the study, and many of the women who we interviewed about why they participated said, because there was a Latina physician running the study, because the navigator spoke my language, because you connected with a doctor in my FQHC, Federal Qualified Healthcare Center, right, to try to recruit us. And so, again, it can be done. It takes some work, but I think we've all highlighted where the work needs to be done, and we've all highlighted that we want to be doing that work. And so I think that's a great start. And alongside that, I hope that this conversation on cancer for the Hispanic Latino community is one of many, because obviously there's a lot to discuss and a lot of work to be done and a lot of people enthusiastic about doing the work.
Thank you, Maria, for joining us. Fabian?
So this is my last comment. I get it, so I'll make it concise and to the point and exciting. I think partnerships are key, right? Working with other organizations to do stuff. We're not a big institution, right? But I was able to leverage other institutions to come work with us. So we are, through our foundation, we actually have put together this partnership where we have this mobile unit. We're going to have this great truck that was repurposed. It used to be a blood bank, and now Next week, it's all done and beautiful, and we're going to start hitting the streets with it to provide more of this education. The partnerships are key. And like, I'm not going to go through all of your names, but I know a lot of you are touched on this. We work with consulates, right? Just as was mentioned, in New York, you work with all the consulates, right? We work with 7 consulates, todos Latinos. And as long as the leaders of these communities also believe and are front forward with the activities, and they're getting their blood drawn, and they're seeing and they're showing that it is, and they're integrating the community, that also moves things forward, as you have been mentioned with the families and things like that. Church is the same thing, is another area that we're working in to expand into that. The training of providers is something, and it's not just the training of the providers, is giving them the access. So from I'll tell you, from HHS, I was extremely fortunate. I just interviewed Secretary Javier Becerra on the importance of access and clinical research and Latinos and all that stuff. And we both agree that just because the provider has never conducted a clinical study does not mean that provider cannot be in the study. And if you want Latinos, if you want more oncologists to do research, stop making them go through this stuck between a rock and a hard place where they've never done a study, so they can't do a study. That does not make any sense, right? So we have to continue to educate the different organizations, continue to educate new providers to conduct clinical research and move this needle in the proper way. And the last thing is to seed the idea to patients, so that when they hear one of these pharma companies or they hear the word research, they already know it. Don't just bring it to them for the first time. And that's why they may not participate, because they've never heard of this. So let's work on continuing that message, so they know eventually if something comes down, they're going to say, oh yeah, I remember hearing that on TV or hearing it on the radio, because that is something that could help me. And I think putting these solutions together are truly an answer for success for our communities and our providers.
Narcis, we're going to have to hold it there. Thank you. Thank you.
Ivis and Narcis going to share 2 minutes. They get 1 minute each, and then I'll hand it over to you. I want to say, I'm going to take 10 seconds of that and say thank you, everyone. There's a lot of faces that are not here. That's behind the scene, IT, everybody else who have helped contribute to this show and making it what it is. I just want to say thank you on behalf of the entire team. Over to you, Ivis.
So, as a patient myself and doing the work that I do, I'm passionate about it. And I'm so happy that everybody is here. And I think we've all put it together in a sense that we connect, we're able to help, and even the smallest organization can do so much more. But we need to expand that. And as you mentioned before, collaborating. And I just want to end it with Podemos, nuestras voces cuentan.
NJ.
So my take-home message is you don't have to wait for systemic change. The power of one is enough to create equity. All of you can create equity. You don't have to be a healthcare provider. You don't have to be in. You find somebody lost in the hospital, help them get where they need to go. You can hold the elevator. You can ask your patient, do you have enough food at home? I'm not waiting. I haven't been waiting for the last 10 years. And that's how the Flores Lab is the Flores Lab. You can create equity. No more excuses. Come with us, get on the field, let's in the community, bring your Tupperware, because if you're going to a church, I assure you, you're going to have some food to take home. So let's do it together.
We heard it from the front runner. Frank, I do want to make sure that you get an opportunity as well.
Yeah, more than a closing comment, I just want to make a pitch for survivorship in the Hispanic community. Cancer survivors, Latino cancer survivors, show poor quality of life and greater disease burden relative to other groups. We're not quite sure why that is the case, other than social determinants of health, but we now have an opportunity. We have a survivorship cohort study of Avanzando Caminos, which is a cohort of 3,000 Latinos in Miami and Texas, which will give us diversity in that community. And I hope that we can continue these conversations and talk about the survivorship experience of our Hispanic communities.
Excellent. And Marcia, you were one of the first people to jump on board with us years ago. So I do want to make sure we hear from you as well.
But yeah, I think I commented already, but this is terrific. I mean, that you guys have been leaders, really pushing the diversity from day number one. And you have actually put policies, guidance that are making industry, are making people that really have the power to include people like us. to include us in in clinical trials. So thank you for what you're doing. Thank you for this wonderful opportunity, and I'm looking forward to continue to work with all of you, reaching out to the community and building partnerships. Thank you, thank you.
Thank you. Now, I do want a special thanks for Donna and Luxon, who, again, great team members collaborating on pulling this all together and reaching out to many of these panelists themselves months ago. So thank you both for all of the hard work. Rick, final thoughts?
I have been relatively quiet, which is a unique thing for me because I've been so fascinated by this discussion. I'd just like to emphasize many companies feel that we deal with and stakeholders that they've met their obligations simply by translating an informed consent into Spanish, which is ridiculous, okay? It's a much more nuanced involvement that they have to have with understanding the complexities of the community, and with the understanding of that complexities, how to address the issues here at hand for each of the communities in the Latino and Hispanic communities that we have in the United States. So I've been fascinated by this conversation, and let's have more of it. And we look forward to further interactions with all of you.
Ria, one more thing. I said was going to break records. This is another record. I'm going to ask Donna to say one more thing, and then you can make that final announcement.
Okay.
So I just thought this has been a fantastic panel, such an array of diverse expertise. And I hope what you hear is the passion about improving health within the Hispanic and Latino communities. So we will build relationships, build collaborations. Muchas gracias. Avanzando juntos. Ria, to you.
Okay. With that, thank you all. Great participation today. Our next conversation on cancer actually will be celebrating Richard Pazder, who is now marking 25 years at the Food and Drug Administration in oncology. So talk about forerunners and front runners and people moving policy, et cetera. We're going to have former commissioners who will be on board to talk on October 23rd, beginning at 2 p.m. Eastern. Look for our social media on that. And don't forget this week to use social media to promote National Hispanic Latino Family Cancer Awareness Week. We are grateful for this panel. We're grateful for everybody who's listening. And thank you so much. Muchas gracias. That's the best I can do.
Adios.
Okay.
Gracias.
Bye-bye.